Shoot Ram. Get in. Pandra very good. Hi, good day to you all. Shuram, shall we start? Good day to you all. It's particularly some doctor is sitting in Eritrea. Hi, doctor in Eritrea. Good day to you all, the spectators from various member countries of Africa. It's my great privilege to introduce today's speaker, Dr. P. Manohar, to you. Dr. P. Manohar completed his MBA cardiology in 2007 at Bombay Hospital, Mumbai, MRCP from UK in 2006. He underwent 6 weeks special training in heart failure clinic management and heart transplant in Ohio State University in end of 2009 under eminent cardiologist Professor William Tauber Abraham, who is well known in those states. To his credit, he delivered many lectures in various conferences at regional, state, national and international level in number 23 conferences so far, apart from including in Turkey and Thailand. He delivered the lectures on various interesting topics like Eplerenone, present role in cardiology, hypertension, confusing guidelines, hypertension management, what is new, heart rate, a new target, win over diabetes, beta blockers in cardiovascular diseases. Also, he has 3 publications in reputed international journals like refractory angina, fact or fiction, failed thrombolysis, vulnerable plaque. All were published in International Journal of Medical Today in January 2005, December 2005 and January 2006 respectively. Now, Dr. P. Manohar is the Associate Professor, Department of Cardiology in our University Hospital. Apart from his regular teaching and clinical practice, he is a co-investigator in many research studies, at present 6 projects. He has many firsts in his academic career, example school first in school final examination, first prize in Mediquiz at the 24th annual conference of Association of Physicians of Gujarat in 2003, first prize at both college and state level in 11th Indian Academy of Pediatrics in Vadodara and Surat. I can talk a lot about Professor Manohar. Due to time constraint, I would like to end up with this. Now I welcome Dr. Manohar to deliver the lecture. Welcome, sir.
Thank you. I hope it is sunny out there in your countries. In our country it's raining, so I hope you have a good morning, and I believe most of you must be having an early morning. Good morning to all of you. I am here to discuss about something which is very relevant to people like you and me, to third world countries, to countries where infrastructure is limited and disease burden is huge. So I would like to start off with this whole concept called concept of heart failure clinic. When we mean by heart failure clinic, why it is so important for us to discuss these issues. So I would like to start off with, can you hear me? I hope you can hear me. Yes, okay. First of all, I'll like to extend a warm greetings from the entire Ramchandra Medical Fraternity to all colleagues, as well as to the from the entire country to people in Africa. To start off with, unfortunately I don't have data from Africa to give it to you to say that what is the heart failure incidence. I'd like to start off with data from US. So because all of us tend to get a lot of information from research in US. So to start off, we should understand that in a country of 250 million, America is a population of 250 million. Of this, 5 million Americans have heart failure. That means The incidence is almost like 1 to 2% of the general population. And most importantly, 500,000 are diagnosed new annually. That makes it of epidemic proportions in the upcoming future. And in America, people always talk of money. So if you compare in terms of monetary terms, America has a 27 billion annual health care burden just because of heart failure. And of this, unfortunately, despite such a large number of Americans suffering from it, the number of deaths remain extremely high. Why I am stressing on this part is, despite the fact that America has reduced its deaths due to myocardial infarction in a significant fashion in the last 50 years, it has not been able to reduce the same with respect to heart failure. In fact, death in heart failure has been steadily increasing over the years compared to what it is in the field of, say, myocardial infarction. And if you list in US, you must be aware that they do coding, that is, they try to list the cause of admission. And if you go by that cause, it becomes the leading cause of hospitalization in people who are more than 65 years of age. That gives you the public health importance of heart failure in the community. What is more important is, I told about 27 billion in heart failure treatment. Of this 27 billion, 14 billion, almost like more than half of it, is used in the acute admission itself. That means for emergency admissions for heart failure itself takes away 14 billion of their money. And of this, there are around 3.5 million hospitalizations annually. I told you about a population of 500,000. That means an average, what is happening is, if you count, like a single person is getting admitted at least 7 times a year. And that gives you the whole concept as to why something is drastically required to reduce the heart failure admissions. And the most important statistics comes after that. If you see, 1/3 of the patients who get discharged from the hospital get readmitted in the 90 days. That means 50 million, 500,000 get admitted, that is 5 lakh population gets admitted, and within 1/3, within 90 days, that is within a span of 3 months, 1/3 of them are back in hospital. And more important thing is, every time a patient is readmitted, the chance of his mortality is close from 8 to 20%. That means any guy who gets admitted, say, 10 times in a year, the chance that he will not be alive the next year is very, very high. And that is where the whole concept of heart failure clinic comes in. And whatever reason you get admitted for heart failure, the chance that you will have a risk of death in the next 6 months is pretty high. These are again, I have taken these projections from the American Heart Association, and if you see, the graph is progressively increasing. This is what I told you about 5 million admissions. 5 million patients are admitted. What do you expect in 2030? You are expecting doubling of the numbers. Believe me, heart failure is the only cardiovascular condition which is increasing with every decade. All other conditions are reducing. Myocardial infarction, this stroke, every other aspect of cardiovascular disease is reducing over the years. But heart failure admissions are progressively increasing over time. So that gives you a clue as to how the expected future is going to be. Coming to heart failure mortality, it is very surprising if I tell this thing to even my doctor colleagues. Many of you might be doctors. If I tell you that cardiovascular mortality or mortality due to heart failure is higher than any known cancer, nobody will believe me. But this is hard data. If you compare any malignancy and you compare the 5-year survival in the malignancy, you will find that in any malignancy, the mortality is around not as high as it is in heart failure. For example, in heart failure, what happens is the expected mortality for somebody with acute heart failure over the next 5 years, if you compare, the survival is only 50%. This is worse than lung cancer, this is worse than breast cancer, this is worse than any cancers which is commonly seen. Why I am stressing on this part is, unless we realize how bad it is heart failure, it is very difficult for us to envisage a situation where we can find treatment for heart failure. So to put it in statistical terms, again I am quoting American data, 2,50,000 deaths every year and 50% mortality. This is what I was stressing. In next 5 years, 50% are going to die. Third thing, 50% of deaths are sudden cardiac death. 50% people die suddenly and 50% are pump failure death. Why this is important is, I don't know how people in Africa accept sudden death. The acceptance of sudden death is very different in US and India. In India, if somebody dies suddenly, the family is very happy. No, I may sound little sadist, but that is how it is. If somebody dies suddenly, the family thinks, oh, good, that fellow died without disturbing anybody, without creating any discomfort to his fellow men or his family members. Whereas in US, the approach is different. In US, if somebody dies suddenly, everybody feels there is some mistake or some error on the part of the treating physician, that this patient could not be, the death could not be prevented. And that is why you must be aware the incidence of usage of devices like implantable cardiodefibrillator is very high in the US compared to poorer countries like India and many of the countries of Africa also. Important to note that although 50% deaths are sudden, 50% of these deaths occur in class 1 and class 2 patients. Why I am stressing on this point is, there are many people who are not prepared for death. People in class 4 are always prepared for death, kind of mentally, financially, socially, and it becomes a kind of an acceptance of death. Whereas that doesn't exist with people in class 1 and class 2. People in class 1 and class 2 always think that they are fine, till one sudden day they have sudden cardiac death. And these are the subset of population who maximally benefit by device therapy. So why it is important is, device therapy is particularly important for this subset of patients, because by giving a device to somebody who is say 15% EF, class 4 symptoms, you are just prolonging his misery. By giving it to him, you are preventing sudden cardiac death, for whom sudden cardiac death will be kind of a liberation. Whereas sudden cardiac death for somebody who is say 30% EF with class 1 symptoms and he dies suddenly, it is a very, very big loss to him and the family. So we have to understand that these subset of patients are the key patients that need our attention. This is just to show that how much heart disease contributes to this thing. So if you add up heart disease and stroke, basically occurring because of similar atherosclerotic reasons, then practically you have half of the more than 1/3 of the deaths occurring exclusively because of atherosclerotic heart disease, either heart or the brain. And if you see, people dying of diabetes alone itself is very less. It is the complications that kill people more often than this thing. This is again American data. Individual data in countries, your country and ours, might be different. I'll just go through briefly through how heart failure is classified and how it is managed. Clinical classification, we all know: acute, chronic, acute, decompensated. Why I have kept it in these three categories is, acute categorization is known. We know the acute classification. Chronic is somebody who kind of presents as an insidious onset, not like patient comes very sick and this thing. Acute decompensated is far more commonly seen. What you see in clinical practice is, people have present to you with symptoms and then suddenly they go back home and one day they come back in florid pulmonary edema. These are the subset of patients who really need proper attention, because there's something happening in them which you are missing every time they get readmitted. This is obviously New York Heart classification, class 1 to class 4. The important thing in New York Heart Association classification that is relevant to you is that patients can go from 1 to 4 and 4 to 1. That is, they can come very stable, become very sick. They can come very sick and become very stable. Why I am stressing is, the other classification, it is a one-way road. There is no regression. There is no backward. Once you go from one stage to another, you don't come back. Whereas in New York Heart Association, since it's a symptomatic classification or a functional classification, there is always a role for person to improve. That is, the condition to diminish. So New York Heart Association classification 1 to 4 mainly says that symptoms at rest, mainly says that it is a classification only meant to grade people when they present to you clinically. The stages that I was talking about is this. ACC-AHA classifies heart failure into A to D. The important thing is, what I am stressing is, somebody, if they are in C, they cannot be in B. They can only go on to D. So somebody can be stage D heart failure but class 1 symptoms. Somebody can be stage 2 heart failure, stage B heart failure, but class 4 symptoms. Like some lady, 85-year-old lady, comes with normal LV systolic function and grade 3 diastolic dysfunction, comes with pulmonary edema. Technically she is in stage B because there is no structural, no symptoms before this. So she was in stage B. But when she comes to you and gets admitted, then that lady migrates to class 4. At the same time, once she improves, she goes back to stage B and without any signs and symptoms. Or she may be in stage C. At the same time, you may have somebody with stage 4D and class 2 symptoms. This is just to say that heart failure diagnosis is not just a clinical diagnosis, but it is an amalgamation of all the presenting complaints. That is, patient having systolic dysfunction, diastolic dysfunction, all form the entire ambit. If you see, this is the subset of people whom we develop clinical suspicion of heart failure. But if you see, there is a lot of overlap. That is, people with EF of 10% may be asymptomatic. People with grade 3 diastolic dysfunction can be asymptomatic. Patients with wall disease can be asymptomatic. Patients with fast atrial fibrillation, some of them can still be asymptomatic. So it is very important for us to realize that it is only in this subset of people who fall in between are the subset of people whom we realize that they are having heart disease. So it's very, very important to realize this. I'll just go through the treatment algorithm. I'll go through two guidelines. One is the NICE guidelines from UK and another is the ACC-AHA guidelines. I know all of you manage patients more frequently. It is just to tell you how the important investigations are recommended in different guidelines. For example, if you take the NICE guidelines, it's very clear. Anybody suspected of heart failure, you need to first rule out heart failure through ECG and BNP where available. In US, BNP is not still included in the top of the list. But since in NHS you have a structured program, they have said anybody comes to you with heart failure, do a ECG, do a BNP. If it is normal, BNP is normal, don't consider possibility of heart failure. Both are normal, heart failure unlikely, consider alternative diagnosis. Once these two are done, you go to the other battery to exclude other conditions. They have talked about urine examination, creatinine, full blood count, thyroid function test, liver function test, glucose and lipid analysis, urine analysis, spirometry, peak flow. Once one of them is abnormal, next step is to go to echocardiography. And no abnormality detected, that means you should think about other possibilities, unlikely, but you should consider diastolic dysfunction still. And in case it is abnormal, obviously you should assess the severity, treat it, and correctable causes should be identified, and you should be referred to heart failure. I'll go through it again. Simple. Patient has symptoms, do an ECG, do a chest BNP. If not abnormal, don't consider heart disease. If it is abnormal, so if it is normal, don't consider heart disease. If it is abnormal, then go for the routine evaluation of all the parameters. If everything is anything comes up, you treat that condition, and the other way around, it is abnormal, you do a echocardiography, and echocardiography can divide it into the three conditions where you can treat the three conditions. Similarly, this is the American guidelines. American guidelines, as I told you earlier, divide people into stage A, stage B, stage C, and stage D. In stage B, A is people who are at high risk of heart failure but without structural heart disease. In these subset of patients, like patients who are hypertensive, patients who are diabetic, they are obese, they are at high risk, but they neither have symptoms nor have signs. So these kind of patients do all these lifestyle changes. You treat hypertension, encourage smoking, treat the lipid disorders, discourage alcohol intake, control the metabolic syndrome. Only one group of drugs are recommended, that is ACE inhibitors. In this subset, no other drug is recommended. Stage A, people at risk of heart failure, you have to try to give ACE inhibitors to all these patients. Okay, that means all hypertensives and all diabetics, because they all are in stage A. Now, patient with stage B, that means patient has a heart disease. Patient has a heart disease, but does not have any signs or symptoms of heart failure at that point of time. That means when patient presents to you, he is an old history of anterior MI. EF is 50%. Do you think he is heart failure? Yes, he is stage B heart failure. That is, patients who come with no symptoms or signs, but do have what we call as clinical background. That is, they have some evidence of structural heart disease. Those patients we will consider as stage B. Important drug that is added in stage B is beta blockers. That is, once you have a proven scenario where you think patient is having heart disease, beta blockers are must. Beta blockers are the kind of cornerstone of heart failure management. Coming to patients who develop symptoms, somebody comes with anterior MI and then 6 weeks down the line comes back with breathlessness on exertion. You know, the diagnosis is simple. They are in stage C heart failure. Obviously, drugs will be diuretics, ACE inhibitors and beta blockers. If you see, the drug that is added is diuretics. The reason is simple, because diuretics are recommended if somebody has symptoms of heart failure. Asymptomatic people, no diuretics. But once you have symptoms, diuretics are mandatory. Special group of drugs, you can always consider aldactone, you can call that is spironolactone, you can consider ARBs, you can consider digoxin, and you can consider hydralazine. Important thing that I want you to realize, that digoxin is still part of the guidelines. It's very interesting, because every time and now we believe that digoxin is no more recommended. But if you see, in selected patients, still digoxin plays a huge role in management of heart failure. Stage D, that is the stage we see in hospitals. Stage D is guys who have symptoms at rest despite maximal medical management. Those who get repeated hospitalized. These people, now you have to start thinking big. Thinking big means you should consider about transplant, you should consider about device therapy, you should also consider about comprehensive end of life issues. Coming to what we were discussing, in fact, earlier also, that what is the meaning of rehospitalization? That means somebody goes home, comes back to you again. So if somebody goes home and comes back to you again, that is called as rehospitalization. So if you consider that as a situation, what you will find is that 33%, which I mentioned earlier also. But what I didn't mention earlier is this figure. 50% of readmissions are avoidable. Why this happens? Simple. Patients do not come for follow-up, and we physicians are too busy to assess stable patient, and most often inadequate doses of the drug are achieved. Why this is important is, if I ask any cardiologist what dose of ramipril he gives, you know what he will say? 1.25 milligram, 2.5 milligram, 5 milligram. You will never find a cardiologist who will say that I use ramipril 10 milligram in a patient. This is the recommended dose, but it is not used because most of our people are underdosed, because most physicians are scared of starting the new drug. They are scared of increasing the dose, because since they don't have experience, they always worry about side effects. So most physicians would be reluctant to start these drugs at full doses. To give you an example, it is not my own perception, it is the perception of most people. There was a good article published by Bing Liang in Pharmacology Journal. If you see, although we talk in conference about beta blocker usage, beta blocker usage, if you see that 77% are receiving beta blockers, which is good because earlier people were not receiving it. But if you think like that, now if you compare with this data, you will find that although 77% are getting it, target dose is reached only in 6% people. That means 94% of the population is not reaching target dose of beta blockers. If you don't reach target doses, how will you get the benefit? So the key issue is not putting somebody on metoprolol 12.5 milligram BD. The key point is to achieve target dose. Because all the mortality benefit that we talk in trials are there only at that dose that is mentioned in these trials. So if you give 12.5 milligram of metoprolol, you are not doing any benefit to the patient. You are doing harm to the patient. Simply because you are not giving the dose in the ideal dose. Ideal drug should be in the ideal dose. So unfortunately, my patients lose out on beta blocker benefits simply because of the physician's fee to write beta blockers. Problem is they don't have time to up-titrate. That is where we are insisting on the concept of heart failure clinic. We all know Adhere trial gave us 4 more information, 4 important things, tell you everything that is going to happen. Somebody has a high creatinine, high value of burn, he will do bad. Somebody's blood pressure is low, he will do bad. If heart rate is high, he will do bad. If heart rate is low, then he will do extremely well. So another 4th important point is age. So all these 4 issues are very, very important in management of prediction of heart failure outcomes. This is all of you are familiar with. In fact, there is a Seattle Heart Failure Model 2 which is already available in the website. It is from University of Washington. If you feel that you need to download it, you can go to the website. It is freely available in University of Washington website. And the Seattle Heart Failure Model is a predictor. It tells you in your patient what is the chance that this fellow will go on to develop heart failure death. So it is a very good tool in predicting mortality. It uses some commonly used parameters: age of the patient, gender of the patient, whether it is a ischemic etiology or not, what's the ejection fraction, what's the systolic function, what's the cholesterol level, what's the hemoglobin. A point I want to stress here is anemia is also a cause of heart failure. So anybody with heart failure with a hemoglobin of 7, I would be more keen to treat it than somebody who is a hemoglobin of 7 and is is sedentary and staying back at home, whom I can treat with iron tablets. But somebody with anemia and a logical reason behind it needs aggressive treatment. The other parameters are also the nature of the drugs used, uric acid level, lymphocyte count, sodium, and obviously the use of drugs like statins, allopurinol, diuretic, and potassium sparing diuretics. Why so much talk about heart failure, etiology, management, and all these things when my original topic is restricted to heart failure clinic? Why talk about heart failure admission, heart failure treatment, drugs available? The reason is very simple. The shortage of doctors in your country as well as in my country is so appalling. I'll show you only one map. It's a very interesting map. Have a close look at this map. What is special about this map? I think the map is reduced. I have to make it this thing. I have to reduce in fine. I think this should be okay. Oh, okay. Oh, no problem. See, what I want to stress upon is what is the doctor ratio. This is a map which has been made with doctor ratios in mind. That is ratio of doctor to patient. You see here, what is the ratio of doctor to patient in US? 390. You see country like Cuba, what is the ratio? 200:1. Cuba is here somewhere 170:1. And see what is the status in my country. My country, you can see the ratio. Okay, in my country the ratio is around 1700 for a doctor. And see the case of Africa. What is happening in a case of Africa? If you see this, you see in parts of Africa there are places where the ratio of doctor is 50,000:1, except for South Africa, which has a very good ratio. All other countries, even countries like Egypt, the ratio is far better than rest of the world, rest of Africa. But still, rest of Africa, you see the numbers. This shows number of inhabitants per doctor. This shows why we need heart failure clinic. Because number one, most important thing is heart failure clinics work because they rescue the most vulnerable patients, the patients who are most likely to have death in the next 6 months. That is recently hospitalized patients. Number two, they concentrate on class 4 patients. These are the guys who are going to pop off, and these are the guys who need your attention. These are the guys who will benefit by a heart failure clinic. And the most important thing is they titrate drugs to life-saving doses. This is what I told before. Ramipil 1.25 has no meaning. Benefit is there only with Ramipil 10 milligram, and somebody has to write it. And of those who are are not on doses that provide mortality benefit. If you take Ramipil 1.25, you will not get the same 33% benefit that you got with HOPE trial. That is the important message. HOPE trial showed benefit of 33% when Ramipil was given at the dose of 10 milligram, not at the dose of 1.25 milligram that I and many of my colleagues practice. So, mainly the objectives of a heart failure clinic is to define what a clinic means. See, we are not conducting a celebrity clinic. We are not conducting a clinic which caters to the neo-rich. You should clarify what you want from the patient, and you should be very, very clear about what is the patient referral pattern, from where the patient will come, and the role of the doctor who sends the patient there. That is the primary care provider or primary care physician, as they call it in US. What is the function of a heart failure clinic? Function of a heart failure clinic is to have a standard operating protocol for OP management of patient, to improve quality of life, improve patient family education, and make the patient feel that the management of his condition is tailored to his needs, and that is to make management patient-centric. Fourth, obviously, in countries where government is paying money, everybody wants to reduce cost. Also, socially also, even if somebody is paying my father's bill, I would prefer him to stay outside hospital. So, definitely reducing hospitalization also is one of the functions of a heart failure clinic. And more importantly, provide support service to the cardiologist working so that he ensures that patient is stable during the night and patient doesn't have any problem in case of MI. Why does heart failure clinic not come up everywhere? Why there are barriers? Why every hospital should not have a heart failure clinic? The problem is not with the hospitals. The problem is with us. The problem is with us doctors. We are not keen because most doctors think, oh, this is my patient. If this is my patient, how will I refer it to somebody else? So I cannot refer. So it has to stay with me. So biggest problem is fear of losing the patient. And the next specific is lack of faith. I know one cardiologist used to tell me, what you will do in heart failure clinic, give the same digoxin, diuretic and all those things that I can also give. Why I should send the patient to you? This is called lack of faith. They don't have a new thinking. They don't have an approach that if they have faith, then only treatment can be successful. Fourth most common is the lack of trust. physicians think, cardiologists think that they treat the patient best. They don't realize that in an organized fashion anybody can treat the patient well. They think it is only them who treat patients in a very sincere and a very perfect manner, and that is the reason why the doctors are not keen to treat. And most important is what will the patient think. You think from patient perspective, he has to go to one cardiologist for opinion, cardiologist sends him to interventional cardiologist for procedure, cardiologist sends him to electrophysiologist for his EP work, he sends him to the heart failure clinic, then he sends to the diabetologist, then he sends to the nephrologist, she sends for the ophthalmologist. Like that, it's an endless time pass, and that is why there is lack of communication and there is chance of mismanagement. Why do patients not like heart failure clinic? It is like saying, if you conduct a clinic and give the name label to the clinic, important clinic, how many of patients will turn up? Because there is stigma attached with importance. So similarly, if you put a board of heart failure clinic, so what patient will think? Oh my God, this is a clinic where everybody's heart has failed. Why should I go? Whatever little heart I have will also go. So the concept is wrong. The concept is the label hurts. And it is a complex self-care management. It's not like diabetes. Diabetes you can do, prick, see the test and answer is ready. In heart failure you cannot do like, in heart failure it's a complex management. Patient has to take care about the diet, patient has to worry about the weight, patient has to worry about the medication, patient has to look about side effects, sometimes device therapy. Most important thing which is also common in older people is they have to a degree cognitive impairment. If you ask them what happened when India won freedom, they will have very clear memories. They will have very clear memories from their childhood. But if you ask them, what did you have for breakfast? They may not be able to answer your question. That means they have significant amount of cognitive impairment and lack of motivation. The first thing that my heart failure clinic, my patients ask me is, doctor, how long do I get to live? Is it 2 months, 2 years or 10 years? I tell them very bluntly that you will live as long as you want to live. I know I am trying to sound a little philosophical, but I strongly believe motivation helps, and psychosocial, financial factors. Patient will think, oh my God, I have to pay for the physician, I have to pay for the cardiologist, I have to pay for the nurse, I have to pay for the transport and all this thing, and on top of it I have to come 10 times to the hospital. So patient may think as a financial burden, and most important is multiple comorbidity. Somebody has a borderline renal failure, comes with uremic symptoms, but the cardiology registrar thinks this patient has uremic symptoms, so he should go to urology. Whereas the nephrology PG thinks that in presence of heart failure, they don't treat renal failure. So patient is sandwiched between two consultants, and such things leads to more disharmony among consultants. Referral process. This is very important. Ultimately, if you consider a clinic, you should know from where the patient is coming. Most commonly in our clinic, what we do, once a person is hospitalized with heart failure, I send my physician assistant to see the patient, talk to the patient, counsel the patient, tell the patient, recover, and once you go home, come back once to just have a free look at your heart. I ask them not to pay. I ask them to come back and let me have a look at their heart. So many times what I call is as an exercise ECG. Patient walks around my corridor and comes back, and I say, now your heart rate is 130, that means you need a beta block. So it helps me in the further management. Primary care provider may always come to you referring that this patient has heart failure, he is advising for the management. Then you have obviously people like us, the cardiologist, who may sometimes during a hospitalization for some other purpose, patient would have come for inguinal hernia surgery, they will say refer to cardiologist since patient has heart failure. these patients need not be seen by a physician, cardiologist. They can simply refer them to a physician, and the physician will take all the decisions, and that gives us a lot of information. Obviously, the other common thing is direct walk-in. Walk-in patients in cardiology are not very high, but still it is something which you can consider. So usually in our place we have this concept that we will tell the patient that patient will be taken care by us at the heart failure clinic, but patient will continue to be cared for by the primary care physician. It is not that we are washing away our responsibility or washing away the responsibility. So we always tell patients that you will be looked for heart problems by me. For all the rest of the things, you can go back to a primary care physician. I usually write a letter to them saying that this is done by my coordinator. She writes saying that I work closely with my colleague Dr. Manokar, who is a cardiologist specializing in treatment of heart failure. Together we manage the heart failure clinic, and you will always be seen by me, and I may ask Dr. Manokar to evaluate you. This is what we usually do. Somebody is coming to casualty, somebody is seen and referred, then this is how we manage the patient. I tell the patient that you have to go back to your primary care physician. This is very, very important. If patient does not go back to the primary care physician is very upset. He thinks that you have hijacked the patient. So it is always better to refer the patient back to the primary care physician, even if it is a cardiologist, and ask the patient to follow up with the primary care cardiologist once in every 6 months, so that all the interventional issues are sorted out by them. What happens? When the patient comes, I don't see the patient. The patient is seen by a social worker. And what does she do? She goes through the family history, she goes through the diagnosis. First, what is done is patient is asked, the relative is called, they are asked, what do you understand? Do you know what disease you have? Do you know what is the likely outcome? Because this is very important. Suddenly patient must have developed suicidal intentions. Patient may not have a desire to live by all the bad things that the cardiologist told the patient. So it is important that we have all the data with us. That is, we know what they understand of the disease. And regarding treatment modalities, we should understand the cost limitation. We should understand that there is nothing like unlimited budget in cardiology. The richest of rich men can become a pauper just for undergoing evaluation for all these tests. So the most important thing that should be realized is that the patient's understanding of the cost, the risk and the benefit is very important. The support systems, social, financial that they have is also equally important, because that decides whether they are a suitable candidate for transplant or not. Initially, we do all the basic routine investigations. We do anthrometry, we do height, weight, all these things we do, and we take mid-arm circumference, abdominal girth, we make hip to waist ratio. All these things undergone in the first exam. Then we assess the symptoms, common symptoms like dyspnea, palpitation, chest pain, arrhythmia, pedal edema, cough with expectoration, hemoptysis. All these things form a common platform where we evaluate the patient and look for signs and symptoms. Investigation, we always do baseline investigations like hemogram, liver, renal and thyroid profile, and also we look for cardiac biomarkers. Cardiac biomarkers, according to me, are the most crucial. They are the most crucial element of assessment. So cardiac biomarker assessment is very, very, very vital in prognostication and also in taking management decisions. Then we proceed to imaging. In imaging, we usually go for an ECG, echo and a 6-minute walk test. Usually we tend to restrict ourselves to these evaluations in the beginning. 6-minute walk test, we have a big corridor in our hospital. We have marked points and we make the patient walk around and count. Anybody walking less than 300 meters is having bad prognosis. Although there are limitations, people with severe orthopedic disease, people with asthma may not be able to walk. But for the baseline cutoff, Anybody below 300 meters is bad. That means their prognosis is bad. Then we have lot of quality of life assessment scores like MLHW, Milwaukee Living with Heart Failure Forum, and also other conditions like Kansas City Cardiomyopathy Protocol. All this give us a clue. Functional class we discussed above. Usually 24-hour Holter is always a better modality of treatment. Patients always need cardiac catheterization 1. It is very difficult to label anybody as dilated cardiomyopathy without any proof that patient has not taken no coronary anatomy is distorted. Similarly, nuclear imaging for assessment of viability, CT and MRI for the same, for functional assessment, for aberrant origin of this thing. Self-management, obviously compliance with evidence-based medicine is more. You give the basic advice to reduce salt intake, to reduce fat and cholesterol, to reduce fluid intake, to eliminate alcohol consumption, increase in activity and exercise, and monitor weight daily. Tell all your patients to buy a weight machine. It doesn't cost that much, but it gives you a lot of information about the cardiac status of the patient. Whatever status, if you don't have pain, I think you should continue having this assessment on a regular basis. Then you ask the patient, what does the patient understand? What is meant by salt restriction? What do you mean by fluid restriction? So you should understand that self-management of heart failure revolves on compliance with evidence-based medicines, adoption of low salt diet, adoption of a reduced fat and cholesterol in diet, stop smoking, eliminate alcohol consumption, routine things. Patient, you should ask patient, what do you think you can eat? That will give you more clues as to his understanding of heart disease than you talking blah 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 for 3 hours. What to eat, what not to eat, when to eat, special situation if patient is traveling. So how to manage fluid and salt at the time of traveling. And you should educate the patient that certain things, bakery products, they are not salty in nature, but still they contain a lot of sodium, because to bake a pizza you have to put lot of soda in it. What is soda? Ultimately it's sodium bicarbonate. Sodium bicarbonate is bad, is equally as bad as sodium chloride, that is salt, because according to us both may be different, because salt is salty whereas soda is not salty. But if you compare in this situation, definitely bakery products, all these things are important. So you should always monitor these things. You should explain to the patient about smoking, substance abuse, smoking cessation. You should tell patient about the exercise prescription. You should tell the patient what to avoid, like muscle building, weight building. These are to be avoided in heart failure. And also, unless patient has problems performing a sexual act, there is no need to advise that patient should not have normal physical relationship. Unless patient tends to go into dyspnea on exertion with palpitations, with pulmonary edema during the course of intercourse, I personally recommend patients to lead a normal life till they have any symptoms with medication. Each drug has to be taken. What we do is we take the slip, show it to the patient, tell, see the color of this drug, see the name, this is 1 milligram, this is 2 milligram, this is 4 milligram, like that we show it to the patient, and then ask the patient to remember. We tell them, if you take this drug, heart pumping will be better, you will be less symptomatic. When we give the water pill or the diuretic, we show it to the patient that this is the water pill, this is increases your urine out. The side effect is you may have cramps, you may have pain. Then you should explain about drug interactions, what drugs the patient is taking and drugs to avoid. Also, at some point of time in the heart failure clinic, you should broach on the subject of end of life issues. You should discuss what the patient wants, whether the patient prefers a sudden cardiac death like situation or prefers a pump failure type like situation. So accordingly you have to take decisions. The most important thing is talk about hospice management in case patient is having repeated admissions, and even consider organ donation. In fact, when I was in the US, one of the things which I liked a lot is they gave me an example of a boy who was on a transplant waiting list. He had LVAD in his body and he died of a CNS event, and he became the first organ donor who himself was on the transplant waiting list. I am narrating this just to convey the message that it is ultimately how much we motivate our patients, how much we talk to them. Though patient is managing heart failure on his own, patient should be advised as to when patient has to seek medical attention, when to come back, whenever we have scheduled a follow-up visit. Otherwise, he should come with new symptoms, worsening symptoms, he has some side effect to the drug, or he has a shock delivered by the ICD because it needs interrogation. At every visit, you should consider whether he is suitable for a pre-transplant evaluation. Follow-up visit, as I told, in case patient has new symptoms, sign. During review, we always check weight, labs, and we always check for drug history, anything new. What next? We always try to up-titrate the drugs, refer him to concerned specialties for small problems, and most important, consider a pre-transplant evaluation. This is usual pre-transplant evaluation that we do. Role of physician: always tell him what you are doing. If you do not tell him, you lose him. If you lose him, you lose all the patients that he refers to. So please never make this mistake of taking individual decisions. Always keep the primary care physician in the loop. And also all non-related heart failure related things. Patient need not come to the heart failure clinic just because patient developed diarrhea today morning. He needs to go to a doctor who can manage diarrhea and at the same time know what drugs not to be given in case of diabetes. Okay, and that is the reason why we always refer back for patients with comorbidities to the concerned primary care physician, and to ensure a degree of continuity of care. This is our proposal. Usually this is our staffing. I head the heart failure clinic in my university. We have myself working as a cardiologist. We have the nurse practitioner who has training in heart failure. Then we have a hospitalist. It is very important for somebody to take care of the sick people, somebody to intubate patients, somebody to be available in the night at emergency, and they are the guys who are going to take care of the daily running show of the patient. Typical patient flow: when patient comes in, say at 10:30, goes to the X-ray, gets all the investigation done, meets the pharmacist who goes through the drugs, checks for old drugs, checks for drug interaction, and then we proceed. Patient meets with nurse who takes the vitals and administers the 6-minute walk test. Then patient goes to the nutritionist, and last at 1 o'clock the patient meets me. This is just to show how new appointments and things would be managed in a busy heart failure clinic. To conclude, whatever we do, we need proof. We need proof that we are effective. What is the measures of our outcomes? Most important is how many deaths I have prevented. Just because some patient is in heart failure clinic, is the mortality less than the national average? That gives the maximum validity for my work, and that gives you a lot of clue. Plus the readmission rate, the chance that patients will get readmitted, say in next 30 days, it depends on how well the patient is claiming in a heart failure clinic. Similarly, we always assess, like as I showed you before, number of patients achieving full doses of drug, and that gives you clue on the management. Similarly, you also sometimes do go for functional assessment like 6-minute walk test and things like that, and take a clue. Then we also look for clinic provider satisfaction and feedback. We send feedback forms to consultant physicians, cardiologists, and ask them to give a feedback, and that forms the basis of further management. Then always we assess patients for transplant. Thank you very much. Thanks for a patient hearing. Thank you. In case anybody has any specific queries, please feel free to ask. Hello. Thyroid. Can you hear me? Thyroid function test is required because hypothyroidism is one of the correctable causes of heart failure. So I always prefer to do thyroid function test because even in 100 patients, if I pick up one patient with hypothyroidism, I am giving him a reversible cause of heart failure. So usually we do thyroid function as a routine so as to not to miss out on patients with heart failure.